Thank you everyone for coming to our 7th session in our series, Serving Patients Experiencing Homelessness. We have two amazing speakers, Sean Haggerty Jr. and Sheryl from the Zumbro Valley Health Center. Without further ado, please introduce yourselves and take it away.
Hi, everyone. My name is Sheryl. I work at Zumbro Valley Health Center. I'm the Housing and Homeless Services Manager. I have been here for quite a few years, so we'll talk to you about the homelessness in Rochester and the services that Zumbro Valley provides.
Hello, everyone. My name is Sean Haggerty Jr. I'm the Housing and Homeless Services Supervisor. I've been with Zumbro Valley for probably about 3.5 years, but in the mental health field for going on about 7. I'm relatively new in my role. Most importantly, I've served on the homeless service team for about 3 years prior to just stepping into my supervisory role. Zumbro Valley Health Center, we are a nonprofit located here right in Rochester. We serve both Olmsted County and Fillmore County, and we're considered a CCBHC. A CCBHC is a certified community behavioral health clinic. We are basically a one-stop shop, and that's how it's designed to be. CCBHC is a federal mandate for us. It's designed to provide a comprehensive range of both mental health, substance use disorder services to vulnerable individuals. Some of the services that encapsulate Zumbro Valley, we have a detox, we have an inpatient residential treatment, we have both adult and children's services. We also have psychotherapy and psychiatry. We do have some primary care as well. So in this model, it's designed to be that one-stop shop for a client. So they can go in there with the intention of, I can get a lot of my needs met right here. We also really strive as an agency at being very integrated between different services. Our clients, especially even the ones that we serve, even on the homeless service team or in our housing programs, are connected with a ton of different programs that help best support them in maintaining their housing or helping them find their housing. We also are involved in the crisis line. We do have crisis response workers, and these individuals actually carry the phone and answer some of the calls either on hours or after hours as well. And we help in providing some of those services.
Zumbro Valley is a large organization. It has grown a ton over the years. We've kind of been witness to that in Rochester. We have 3 different locations. One is out at Woodlake Drive. We have one at Greenview. Sean and I work out of the 7th Street building, which is downtown. We are strategically located so that it's convenient for the people that we serve. Sean and I work with primarily the long-term homeless population, and we really do focus on the long-term homeless population. And people have to meet that diagnostic criteria, either long-term homeless or chronic homeless, to qualify for many of the services or housing programs that we provide. The definition of long-term homeless is the person has to be homeless for at least 1 year continually, or have 4 episodes of homelessness in the past 3 years. Sometimes we get calls and it's like, mom's got an 18-year-old, they're smoking pot in the basement and he needs to go. That's not the population we serve. The population we serve are the people that are homeless on the streets or possibly doubled up with someone and it's jeopardizing that person's housing. We are working with people that have been homeless for a long time, people that may have just housing instability where they can find a place, but they're not able to maintain it. So they have those kind of episodic periods of homelessness. About 30 years ago, I think it was 1992, we started with one housing program for the homeless, which was a HUD-funded program. It's called Shelter Plus Care. We still have that program today, but we've added a lot more programs, different funding sources, different criteria for getting people into housing. And currently our staff of about 10, 11 people, we currently have today 156 households housed. That means they're renting apartments in the community, maybe a small house in the community, some families living with their children. Mostly we focus on single adults. With the housing and the funding to help pay the rent, the subsidies for the housing, our staff provides supportive services. We are very involved with the clients that we serve. We're very hands-on because the folks we serve don't have, I'm speaking very general, but for the most part, don't have the skills to live independently, especially when we first house them. And really have to learn kind of how to do that. So staff are there and whatever it takes to keep people housed is what we do. We transport clients, we help them with shopping, we get people to their medical appointments to make sure they do get there. All those kinds of things. Initially, when they're housed, it's very busy. It's setting up household. Generally, when people come in, they have a backpack and that's it. And we may be able to find them a house or an apartment, but then they need everything that goes along with that. So it's very busy with getting people set up for housing, getting their household established, getting the furniture they need, all that kind of thing. And people have gone without services. So it's really looking at what they need, getting those services into place, but it takes time. And part of those services is their medical care, because oftentimes that's neglected.
I just wanted to ask this question because it was asked of us. What would you like physicians to know to better serve the people you work with? One thing that I thought of that just trust and rapport is extremely important when serving someone who is homeless and maybe it's their first time seeing a doctor. By and large, I have a lot of clients who have done care coordination for, and this is the first time they see a physician, and they are absolutely anxiety ridden. People just in the general public have an aversion and a fear of going to the doctor. And then you heighten that with someone who is potentially homeless and dealing with a lot of other things. That's a pretty scary experience. You're stepping into a place that's completely foreign and unknown to you. So really taking that time to just build a little bit of trust and a little bit of rapport with those folks, it's a great first step. You'll see dividends just in that relationship. The other thing I'd really impart upon you is that homeless person, you may be the one person in their life that they can count on or have a little bit of support from, or they may have support such as a case manager, care coordinator, caregiver, friend. But for a lot of our folks, we are it. We are that person, that advocate that helps them through this kind of unknown process. One thing I've seen, sometimes my doctor might ask, so what's wrong with you? And a lot of homeless people are really taken aback by that. Thinking about it through more of a trauma-informed approach, we maybe would ask, hey, instead of what's wrong, what happened to you? One thing that I really want to stress too, homeless people have amazing, amazing abilities. I think of just their survival instincts, and they have a lot to offer. Playing to their strengths, and also, again, just building that relationship. Because in the end of the day, that relationship that you build with them is going to help you with them following your recommendations, your orders, them making it to appointments. So again, I really focus on just building that relationship, building that rapport, and taking it kind of slow with them too. These folks are medically pretty complex. So in treating them, throwing a lot of jargon at them, also just throwing a ton of you need to go see this specialist, this specialist, this specialist, it's going to be hard for them to manage. If you're working with someone who does not have that extra support, such as case management or even care coordination, you're going to run into some issues with them just getting to appointments. The other thing is, and Sherry, maybe you can speak a little bit more to this, respect is also a really big factor.
The respect is something I have learned over the years. Everybody wants to be treated with respect. And these are folks like anyone else. And to treat the person and not the disease, or kind of leave the judgment behind. Because even the littlest disrespect, and it could be the way you ask a question, it could be the way you look at them, our clients pick up on that. And it really affects them and their willingness to come back. So always be as respectful as you can and take it slow. For folks, this is huge anxiety to get in to see a doctor. A lot of times we really have to talk people into getting treated or seeing a doctor. And if it's not a good experience for them, they're not going to go back. So all the work that we do, even though it's really busy, it's kind of baby steps. Eventually we'll get there, but we have to take it one step at a time. What's great about Zumbro Valley is we have a lot of the services that the population we serve really benefits from. And we are part of that team, and we can help them navigate that and even go with them to appointments. So if you see somebody and they have somebody with them, we wouldn't go with them if they weren't comfortable being with us. And I think we're their support person and we're safe for them, and they're more comfortable probably having their case manager with them or their housing worker or whatever. Make sure you get a release for that and let them be with their staff and not sitting in the waiting room. Of course, we always respect privacy. If the client doesn't want us there, we won't be there. But I think it does help for a lot of the clients that they have their person with them. Another thing is being a little bit lenient on no-shows if they don't come to their appointment. These are folks that are surviving, and being homeless is a full-time job. So they lack transportation. Their cell phone might work today, but it's not going to work tomorrow. They forget their appointments. They may not show, but then when they do, we don't hold that over their head. We're just going to go with what we got now. So I think it's just a lot of patience, it's a lot of respect, and it's baby steps.
I would echo just finding an ally. If a person that's homeless is identified and they have a support person with them, such as that case manager or care coordinator, make an ally because that person sees them day to day. The other thing I would really touch on is just continuing of care. Really important having that long-term relationship. I know y'all work in medicine, so sometimes that doesn't always work out. What I would suggest, especially in that scope, even if you've met with this person a couple of times, but you have to transfer them for whatever reason, do that warm handoff, even be involved in that too. That'll really help build that relationship. One of the best thing about our program is we have folks that we have served for almost 20 years. And the beauty of our program is just that we've built these really good long-term relationships with folks, even as staff has kind of turned over. So it's really important that even a warm handoff to say you have one in primary care, but you're transferring them for whatever reason, maybe you're leaving for a different place or whatnot, having that warm handoff and being involved in that. One thing that kind of gets stressed on us a lot is folks, when they get a new provider, especially when they're homeless, they kind of have to tell their story over again. And it kind of sucks for them. It really does. It's not very trauma informed and it's taxing to them. And really, these people just want to have a long-term connection. And especially if they suffer from that white coat syndrome where they're kind of averse against doctors. Oh, this one left. What's to say the other one doesn't leave too? Just keeping that in the back of your mind. I know obviously in medicine, things change, but really focusing on that relationship part, I think is awesome. The other thing that I would mention is our clientele are pretty medically complex. I mean, they suffer from a mix of chemical, mental health, and physical health issues. They are a puzzle. And doing care coordination for the last 3 years with folks, they kind of get sent down to a lot of different specialties. And we find too, a lot of our folks, they suffer from chronic condition, diabetes. A lot of them smoke, or they just don't lead very healthy lifestyles. Actually with these folks, it's baby steps. When we talk about success with a client, it's not that they're fully independent, but maybe they've been housed for 5 years and that they've been maintaining that housing. Some things might be, hey, instead of smoking 10 cigarettes a day, maybe they've cut down to 5. I know there's probably a lot of doctors internally screaming, oh, this person is smoking, but really in some of our approach, we use harm reduction. And that seems to work the best. The beauty of that is we meet people where they're at, especially in their addiction or even in their mental health. I've come across a few folks that don't even want to acknowledge that they have mental health issues. And I know that each person is individual and it's a case-by-case basis, but really meeting them where they're at is a great thing. And really just keeping in mind of that relationship. Getting creative too, and instead of just saying, I want you to do this, maybe it's getting a little bit more buy-in or figuring out where the barriers are. Keep in mind that relationship. Instead of telling them what to do, maybe ask them, how do you think this is best going to work?
The one thing I wanted to mention that we didn't mention in the beginning is we also have outreach staff at Zumbro Valley. So this is point of entry person. So if you have somebody in the hospital and they're homeless and they're in need of services, you can call Zumbro Valley and outreach can connect with that person while they're in the hospital and kind of get the ball rolling, get things started for them. And also where services are now in the community is the best they've ever been. It used to be when there was someone in the hospital that didn't have anywhere to go after leaving the hospital or when they were ready to be discharged. Now we have places. So you're in a good spot if you're treating people in the hospital and they don't have a plan for discharge. If they're healthy enough to be on their own, they don't have to be outside anymore. So the landing and the warming shelter at night. And hopefully those two programs keep going because Rochester needs them.
I had a question. Do you have suggestions for specific ways that physicians can support patients who are struggling with chemical dependency?
We're a harm reduction program. So abstinence is not a requirement to get into any of our housing programs, but it certainly is encouraged. And we would refer people for a chemical health assessment and then some kind of reduction in use, harm reduction. How can we keep people safer? And Zumbro Valley has several different substance use disorder programs that we would encourage people to go to. But people have to acknowledge that they even use, and sometimes people don't do that. We're seeing a lot more meth use in the community than we've ever seen before, which is really, really tough.
I think as well, when you're dealing with a situation and maybe there's somebody who is completely in denial, it's sort of like figuring out where the change talk is with them, figuring out where the stage of change, where they're at, whether it's pre-contemplation, contemplation, engagement. A lot of what I use, so I'm a mental health professional, so I use a lot of motivational interviewing. Very great start to try to figure out where the stage of change is for this person. It's both a skill and art form a little bit too, kind of feeling somebody out for that. And it's generally pretty tough. A lot of our folks, they are homeless and they also have chemical health issues by and large. And that's really what the data would show. If you're ever interested, Wilder Research does a homeless count throughout the state of Minnesota and in our local municipalities. And that gives a pretty clear picture of what we're facing just as a state and then just in the Rochester, Olmsted County area.
There seems to be this misconception or this idea that there are some people who've been chronically homeless that want to be, and that you can't put them in an environment where they're going to have housing because they don't want to live that way. They want to be free. What is your experience with that? What do you think about that?
My personal opinion, I've been doing this for almost 30 years. I've met one person that wanted to be homeless. Otherwise, no. I don't believe people make a choice to be homeless. I think people make a choice to be left alone and not bothered, but I don't believe that. I think also, though, there's some people that just fail at housing. They can't do it. And it may be because of drug use. It may be because they don't have the life skills to manage it. And it's just easier to be out in the tent, out in the woods. We have a lot more services now than we did, but I don't think we have everything we need yet to serve that population.
I would just add that perception, I think, sometimes is sort of murky just because there could be chemical use involved, mental health involved. When you actually get somebody that is totally at baseline and not being affected by the mental health or the chemical health, probably get a way better idea of, yeah, I want to be housed. You know, the other thing that I would really take away is, by and large, our population has experienced immense amount of trauma. Well, every single one that you come across, they've suffered some form of trauma. I bet money on it. So, and interacting with them, having more of a trauma-informed approach is definitely going to help you out a lot more into getting the details surrounding their homelessness and medical care. I haven't run across somebody who says, no, I don't want housing. It's just they're very specific in what they want. And some of that might be driven by chemical use. Some of it might be mental health. But by and large, people have a right to housing. Unfortunately, it doesn't always work out that way. But if you think of Maslow's hierarchy of needs, safety and security is in that too, and housing is in there too. And it's super important. Once someone has housing, everything else kind of falls into place, the services, getting medical care. So it's a super huge component.
It's been great to have you both talking about issues that are most dear to you. Your passion comes through. We really appreciate the knowledge you've been able to give us.
Thanks for having us.
Thanks for joining us, everyone.